Medurstand. Understanding Medicine.
Professor Aziz-ur-Rehman again, and we are discussing various components of chronic liver disease, and today we're going to talk about cirrhotic ascites. Now, of course, I will be discussing ascites in general also, but my main focus will be cirrhotic ascites because ascites could be due to many causes. Main discussion will be around the ascites which we see in cirrhosis. The definition, it is the presence of free and significant amount of fluid in the peritoneal cavity. Normally we have just sufficient amount of fluid to keep both the layers of peritoneum wet, and there is no free fluid as such. With no technique you can pick it up, but if it accumulates and it accumulates in large quantities, it can become very obvious. Now in this person you can see the overall person's physique is quite thin, but you can see very protuberant abdomen, and I think anybody can recognize that this is actually ascites. Now if you look at from this side, you will see that flanks are particularly full. Now this is another sign that whatever is causing distension of abdomen is free and it's fluid in the flanks. So the very inspection can give you the diagnosis, but of course you would proceed with further test. Now if you examine these patients, there may be clubbing. There are many signs in this patient. Now if you agree, you can see this nails are curved, and the nail bed and the finger, this angle is obliterated. You can see that the angle is obliterated and nails are somewhat clubbed. So there is clubbing, and there is also Leukonychia. That means nails are somewhat pale, indicating the presence of chronic anemia in these patients. Now there are two tests which are done to demonstrate the presence of free fluid. One of them is called shifting dullness. The philosophy of this test is that when you lie flat, fluid will take the flanks, the gutters, the dependent parts, and intestine with its gas contents will float, and this part will be resonant. So if you percuss, this part will be resonant, and as you proceed on this direction or in this direction, you will find dullness because of the fluid. Now if you turn the patient to right or left, then intestine will shift, fluid will shift, and this area will become resonant, and then when you come back to this area, this will become dull because fluid now has shifted to the dependent part. This is what I'm going to demonstrate you in the form of a video. So this is the percussion. First you do percussion and you identify the area where there is resonance, like this one. This is the part of intestine, and you move laterally till you find area of dullness. Not very deep, but somewhere here you will find dullness, and then you ask the patient to turn, and then you wait for a few seconds. The book says 1 minute, but just few seconds are sufficient. Now when you percuss, it will be resonant. And then you come back. Now since the fluid has shifted to this part because of the gravity, this has become dull. So this is called shifting dullness. The dullness has shifted from flanks to umbilical area because fluid has actually shifted. So this is shifting dullness test, which is often done in examinations. You need to have mild to moderate amount of fluid and a lot of expertise to be able to detect this fluid. Now there is another test called fluid fill. If there is large quantity of fluid sufficient to fill both paravertebral gutters and then float over the spine. You know, spine is curved. Spine acts like a barrier in the center and it is curved. So you actually need a lot of fluid to fill both paravertebral gutters and to float over that. And then if you tap here, that wave will be transmitted through the fluid on this side. So the person, whoever is doing this test, will tap one side and feel the wave going to the other side. So this is how it is done. You can feel the tap. And because the wave could transmit through the abdominal wall also, so we will block this. We'll ask the patient to put his hand so that this wave doesn't go this way, and only if there is fluid present, then you will feel the wave. So in this case, fluid thrill was also positive. Fluid thrill is less sensitive than shifting dullness. That means if there is small amount of fluid, it is possible that the shifting dullness is positive, but fluid thrill is not. If fluid thrill is positive, then shifting dullness test has to be positive. Another test which we elicit in these patients, even in this picture you can appreciate the Leukonychia and clubbing. This is the test to elicit to demonstrate pitting edema. You can see that just by the look you can see that the feet are swollen, but there are other possibilities, so you have to demonstrate that this swelling is due to pitting edema. So this is a method. You just press against a bone for a few seconds, and when you lift your thumb you will see the pit. See, this is a pit, and this is because of the presence of fluid in the subcutaneous tissue, and that got displaced by constant pressure and a dip is formed. And there is another type of edema called non-pitting edema, like in patient with hypothyroidism, mixed edema, or patient with obesity. It may look like edema, but that is not pitting in type. So this is the pitting edema, very typical of cirrhosis, and many other conditions like nephrotic syndrome and heart failure, but here we are discussing cirrhosis. Now, types of fluid, we have demonstrated with just simple clinical methods that there is fluid, but we need to determine the type of fluid to reach the proper diagnosis. And there are various types. The most important is the transudate. Transudate is simply the normal interstitial fluid present in the third space. Peritoneal space is one of the third spaces. So if normal body fluid, normal interstitial fluid is present in the third space, in our case in the peritoneal cavity, it would be a transudate. And that is what we see in cirrhosis. Unless there is some superadded complication, we see transudate in cases of cirrhosis. Exudate is a protein-rich fluid, and chylous is the one which we see very opaque, whitish when there is lymphatic blockade. Chyliform is not exactly chylous, but it is like chylous. Any chronic effusion can become chyliform. Sometimes fluid may be blood stained, typically suggestive of malignancy, and sometimes it may be frankly purulent, indicating bacterial infection. So these are various types. In cirrhosis, without any complication, we will see transudate, and I'm going to show you the mechanism, how the transudate and exudate they are formed, and then there are differences. So this is the mechanistic difference between transudate and exudate. A transudate, the capillaries are normal, their fenestrations are normal, but there is increased hydrostatic pressure, the pressure inside the capillaries, and there may be reduction in oncotic pressure. Both of them are actually needed to keep the fluid within the capillaries. If you have too much hydrostatic pressure, that is likely to push the fluid outside the capillaries. And if you have too little oncotic pressure, that is likely to again not be able to hold the fluid inside the capillaries, so fluid will leak out. So both these conditions are fulfilled in cirrhosis. In cirrhosis, there is portal hypertension, and that portal hypertension is transmitted back into portal or splanchnic capillaries, and that leak out fluid. Similarly, in patients with chronic liver disease, there is likely to be hypoproteinemia, hypoalbuminemia, so that will lead to reduced oncotic pressure, and fluid again will leak out. So in cirrhosis, the mechanism of ascites is simple transudation of normal body fluid. So you will get transudate. Now, if you compare it with another condition where there is inflammation or damage to the capillaries, like we get in tuberculosis or malignancy, the capillaries are dilated. As compared to this one, capillaries are dilated. and more importantly the fenestrations, these small foramens in the capillaries, they are dilated. So bigger molecules, proteins, like in this case proteins will not leak out. In this case significant amount of proteins will also leak out, and some cells will also follow them. So you will have a fluid which is protein rich and cell rich. So this is exudate. All right. So from the very nature of fluid, we can actually extrapolate and find out what is the pathology responsible for fluid formation. In our case, uncomplicated cirrhosis, we will have transudate. Pathogenesis of cirrhotic ascites. There are multiple factors responsible for fluid formation. Most important is portal hypertension, and portal hypertension is the integral part of cirrhosis because of the architectural change in the liver. Blood does not flow easily, and also because of the hypertrophied nodules, the regenerating nodules, there is obstruction to the portal venous outflow, and that causes portal hypertension, and that patient is transmitted back into splanchnic capillaries. Hypoproteinemia, because of reduced production of albumin by the liver, there is hypoalbuminemia, and that also leads to fluid formation. So these are two important contributing factors. But we also have hyperaldosteronism. Although the total body fluid is in excess, but intra-arterial fluid is reduced. So body senses it as if there is dehydration and activates this aldosteronism mechanism to retain sodium and water. And we also have elevated antidiuretic hormone in patients with cirrhosis. So all these four factors, importantly first two, I think they all contribute in the pathogenesis of ascites in cirrhosis. What is transudate? A transudate is any fluid. It may be in the peritoneal cavity, it may be in the pericardium, or it may be in the pleura. Any body fluid can be classified as transudate or exudate. It is just normal extracellular fluid, just present in large quantity in the third space. Protein contents are low, and LDH is actually also a protein, but this can be specifically measured, and they also should be low, and cell count should be very low. So this is transudate, and this is what we would expect in cirrhosis. Now in exudate, protein contents may be increased 2.5 or more grams per deciliter. LDH level may be more than 200 milligram, or maybe more than 60% of the maximum plasma level, or cell count may also be increased. Of course, when we take the specimen, there is a possibility of inducing some trauma that can also lead to elevation. But when a procedure is done carefully and there is no significant trauma of the procedure, presence of protein and LDH and cells would indicate exudate and would indicate some inflammation or injury. So in our case, if we in a patient with cirrhosis we see any of these, that will surely mean that cirrhotic fluid is there is complication, some complication like spontaneous bacterial peritonitis or some other complication has occurred. Now, differential diagnosis of transudates versus exudates. The just causes of transudate, we have cirrhosis on the top. That is our subject of discussion for today. But we also have nephrotic syndrome. In a nephrotic syndrome, there is severe hypoproteinemia because protein is lost in the urine. So hypoproteinemia will lead to reduction in oncotic pressure, and there will be a transudate. And in heart failure, again, there is increased hydrostatic pressure in the capillaries that pushes fluid outside the capillaries, so you will have transudate. So these are three classical examples of transudate. Then hypoproteinemia also. Now, exudate, tuberculosis, very common, and tuberculous ascites is often the differential diagnosis of any ascites. Now, if patient has got overt cirrhotic changes, then of course any ascites will be taken as part of cirrhosis, but sometimes there may be additional disease, there may be coincidental disease, and there may be tuberculosis also. So if it is exudate, it would suggest the possibility of tuberculosis, and we will do the remaining tests accordingly to confirm this diagnosis. Peritonitis, one of the types of peritonitis in cirrhosis is what is called spontaneous bacterial peritonitis, and I'm going to discuss this condition in one slide later during this lecture. Malignancy, it could be unrelated to cirrhosis, or there could be malignancy associated with cirrhosis also, like hepatocellular carcinoma is a complication of cirrhosis, and that hepatocellular carcinoma could infiltrate into the peritoneum and could cause malignant cells present and also exudative ascites. So these are the differential diagnosis of transudative and exudative ascites. Autoimmune disease, any type of autoimmune disease, they affect surfaces like cirrhosis, SLE, or other diseases can also cause exudative ascites. Now, there's another concept. I think peritoneal fluid can be easily differentiated into transudate and an exudate, but there is another concept which is applicable to cirrhotic fluid, and that is the concept of SAAG. I'm going to explain to you that. So this is serum-ascites albumin gradient. Serum and ascites. The albumin in the serum and albumin in the ascitic fluid in the same individual, and the difference, that is the gradient. So we determine that person's serum albumin, and we also determine the presence of albumin in the ascitic fluid and see the difference. That will tell us if the cause of this ascites is portal hypertension, which is an inherent feature of the cirrhosis, or it is something else. So if this level is more than 1.1, if the difference of the gradient is more than 1.1, this would be portal hypertension. So this would be a transudate and it will be portal hypertension. Sometimes even if patient has cirrhosis, there may not be significant portal hypertension, there is ascites. So we don't know if there is another cause. So this concept will be helpful. If this ratio, not ratio actually, the difference, the gradient is less than 1.1, that means there is no portal hypertension. So if there is no portal hypertension cannot be responsible for this ascites, and there has to be another cause, and it could be transudate or exudate. For example, if there is additional heart failure, there would be transudative effusion, but this SAAG will be less than 1.1. If it is exudate, then again there will be features of exudate and the SAAG will be less than 1.1. So this is actually to differentiate simple ascites seen in cirrhotic patient with portal hypertension, to differentiate from any other ascites which can coincidentally occur in patient with cirrhosis. Examination is very typical. I told you different methods, but many times we have to proceed to the investigation to finally confirm the diagnosis. The investigation of choice is undoubtedly ultrasonography. Ultrasonography is a great test to confirm ascites, and it will also tell you a lot of other things about cirrhosis. Now, free fluid will be present even when small quantities. If it is small, it will be present only in the paravertebral gutters, in the renal angles. But if it is large, it will be floating. You can see this abdomen, this black color is all fluid, and this is intestinal contents, and all this fluid is, all this black shadow is large amount of fluid. So that can be detected. Helps to tap fluid. If it is relatively small, if it is large, then I think it is easy. You typically tap the abdomen on the like fossa, right or left. Left is preferred because that is where you have the deepest level of fluid, and without any fear of injuring any of the organs, you could take the fluid out. But ultrasound will guide you. If it is relatively small, it is best to perform peritoneal tap under ultrasound control, because then you don't make a mistake. You go directly to the place where there is fluid. So without multiple puncture, without any trauma, without hit and trial, you take out fluid, and that for the diagnosis purposes. Debris may be present. If there is peritonitis, then you can see that there is debris present, and that will help you the diagnosis. And additional features of liver disease or other diseases. Now, that I've already covered on ultrasound. You will see liver is small and shrunken, very echogenic, surface is irregular, portal vein is dilated, spleen is enlarged. There may be a focal defect in liver. So all these things will be determined on ultrasound. But here we are discussing basically ascites. The ascites will be very easily detectable on ultrasound. Ascitic tap is the taking out fluid with the help of a syringe and needle for examination. I think it is not necessary if the diagnosis of chronic liver disease is obvious and if we do not suspect any additional complication. Somebody having all the clinical features of ascites and ultrasound has already shown the presence of cirrhosis, ultrasound has already confirmed the presence of ascites, I don't really think that it is necessary to traumatize the patient, take out fluid for examination. It would be necessary only in certain situations, indicated if you suspect spontaneous bacterial peritonitis. Now, this is a condition if you have a pre-existing ascites, and in individuals, even in normal healthy people, this portal blood may have germs because it drains intestine. In about 60 to 70% patient, even healthy individuals, you can isolate intestinal organism from the portal vein. But normally these bacteria are cleared by a very reliable and robust macrophage system in the liver. Those cells, Kupffer cells. But in cirrhotic patient, these Kupffer cells are reduced in quantity. So these germs, they actually can ooze out from the liver surface and can get entry into the peritoneum. And there is already fluid present and there is addition of bacteria. This will turn into peritonitis. And this is called spontaneous bacterial peritonitis. Why spontaneous? Because the mostly peritonitis is caused by some rupture of organs or some trauma or some complication of some surgery. If peritonitis occurs without any of these, it is called spontaneous. And it is different than usual type of peritonitis because you don't get those classical signs. There may not be guarding, there may not be rebound tenderness, and patient, because there is already fluid, any pus is actually dilated. So you need to have a high index of suspicion. Anybody with chronic liver disease presenting with abdominal pain and fever should be suspected to have spontaneous bacterial peritonitis, and this patient must have a peritoneal tap because this condition carries poor prognosis if not treated properly. Therapeutic tap indicated in massive ascites causing respiratory distress. This is called a therapeutic tap. Of course, you cannot take out all the fluid because fluid is going to reaccumulate, and taking out large quantity of fluid from the abdomen may lead to shock, may lead to drop in blood pressure. So just take out enough amount of fluid to make his breathing easy. So this would be indicated only in those who have massive ascites. So mostly patients with CLD, they do not need peritoneal tap. Those who are suspected to have spontaneous bacterial peritonitis, they need it, or those who have respiratory distress, they need it. Now, what are the tests if you do perform peritoneal tap? What are the tests you're going to perform? I think these are the normal ones, routine tests like presence of protein, the amount of protein, the amount of sugar, the amount of LDH, and the number of cells. This will help you to differentiate between Transudate and Exudate. In cases of spontaneous bacterial peritonitis, this would be increased. Sugar will be reduced and protein will be increased. Absolute neutrophil count. This is very simple way of diagnosing SBP. just count the number of white cells. If they're more than 250 per cubic millimeter, then you suspect spontaneous bacterial peritonitis. And adenosine deaminase, this is very, very brief. This is done in tuberculosis, MTB DNA PCR by gene expert. This is also done in TB, and malignant cells if you suspect some malignancy, and amylase if you suspect pancreatitis. So this I'm not going to go into details because our subject is cirrhotic ascites. Now, treatment of ascites due to cirrhosis, I think aim is to keep the patient little comfortable. We never aim to completely remove peritoneal fluid by medication or by syringe, because if you do that, patient will develop severe dehydration and there will be more complication. So we reassure the patient that this fluid does not do much harm, but of course if it is too much, we do want to reduce it to make the patient comfortable. And the typical long-term therapy is spironolactone, and dose is 100 to 300 milligram. Why particularly spironolactone out of many other diuretics? Because number one, spironolactone causes very, very gentle diuresis. It is not a very potent diuretic. It works for 24 hours and it works slowly. So I think very easy to tolerate. And number two, the theoretical reason that one of the components of the etiology, the pathogenesis of ascites is actually hyperaldosteronism, secondary hyperaldosteronism. So that is why spironolactone is the treatment of choice. Although in some cases we have to add furosemide, because if the patient has got massive ascites and spironolactone alone is not enough, then we give furosemide in combination. These two are available in one pill also, so we conveniently give one. This is a potent diuretic, this is potassium sparing diuretic, so combination becomes potent as well as potassium sparing. In cirrhosis, we cannot take the risk of hypokalemia because that can precipitate hepatic encephalopathy. So that is why we have to be very careful. Either we give potassium sparing alone or we combine it with the loop diuretic. Therapeutic drainage not routinely recommended, only in those patients who are actually very, very sick and they have respiratory difficulty, and we remove only the sufficient amount which makes the breathing easy. Now there are some procedures which can be done. One of them is TIPS. This is transjugular intrahepatic portosystemic shunt. I discussed this in some more detail in my discussion in gastrointestinal bleeding complication of cirrhosis. Those who are interested, they can refer to that video, but very briefly, a shunt is created inside the liver by a minimally invasive procedure to allow portal blood to shunt to the systemic through a conduit and then going to the hepatic vein, and that would reduce portal pressure. And since that is the main factor responsible for ascites, so ascites formation will be reduced. So TIPS is one of the procedures. And then portosystemic shunts, these are surgically created shunts between any of the branches of systemic vein and any of the branches of portal vein. Typically renal vein and splenic veins are shunted, and they, I think they put a prosthesis or they are just stitched together making a hole so that the portal blood goes to the systemic. Both these procedures have some problems, like shunting blood from portal to the systemic circulation may increase your chances of developing portosystemic hepatic encephalopathy. One slide on spontaneous bacterial peritonitis and a complication of cirrhotic ascites. I have actually already explained how this happens. Intestinal bacteria, they enter portal vein and then they get out of the liver surface and enter peritoneum where there is already fluid, and they cause infection, and usually single microorganism, as compared to peritonitis, which occurs after trauma or after gut perforation or after some viscous perforation, where there are multiple organs, and this is usually single organism and usually an E. coli. So either we try to culture and determine the antibiotic, or mostly on empirical grounds we cover these gram-negative and anaerobic bacteria. Cell count of more than 250, and if they're neutrophils in ascitic fluid, that will confirm the diagnosis. Although blood culture should be definitely helpful, culture is usually negative, and then treated with ciprofloxacin or ceftriaxone with metronidazole. This is at least what I do: metronidazole to cover any possible anaerobe, and ciprofloxacin and ceftriaxone, either of the two, would cover gram-negative bacteria very effectively. So this combination should be given, and we have to treat this infection effectively, because peritonitis could be serious, and particularly if this happens in the setting of cirrhosis, it could be particularly serious. We cannot afford to waste time, so I think early action is needed. Prognosis, mostly a nuisance. The ascites itself does not give much of a problem, except that patient is of course concerned, and patient has abnormal posturing, maybe some breathing difficulty. Large ascites can cause a respiratory distress, but mild to moderate ascites, they just cause some distension and nuisance. And prognosis is primarily determined by underlying liver disease, and if somebody has gastrointestinal bleeding or hepatic encephalopathy. As such, ascites is not the very serious component of cirrhosis. Spontaneous bacterial peritonitis can lead to hepatic encephalopathy and septicemia if not detected and treated promptly. So I hope I was able to give you a reasonable account of ascites. I demonstrated you the clinical methods and the fluid examination, and I also emphasize that it is not necessary to do peritoneal tap in all patients if the diagnosis is very clear, but if there is possibility of SBP or if you suspect another disease, then tap should be needed. And those who have respiratory distress, therapeutic tap should be done. With that, I'd like to thank you for watching this video. I'm Professor Aziz-ur-Rehman from Medurstand, and please join me in my next video, which is going to be on hepatocellular carcinoma. Thank you.